Today I was asked to give a brief presentation as an overview of hepatitis C, both the situation and response as well as clinical care in very resource-constrained settings in the region. So I have no disclosures except that I'm not a hepatologist, I'm not a virologist. I'd rather speak with the bias of a public health person, so everything I'll be saying is really from that perspective of the public health response to viral hepatitis. So today we'll talk briefly about the epidemiology of hepatitis C in sub-Saharan Africa, the clinical approach to hepatitis C and particularities from resource-constrained settings in sub-Saharan Africa, the status of the HCV response to date, and some successes and challenges that we've experienced. So we spoke quite a bit about the epidemiology yesterday, the global epidemiology. We know that about 15% of estimated viremic infections worldwide are in sub-Saharan Africa. That's about 1% of the sub-Saharan African population, or about 2% of the adult population in the region. When we look at countries with the greatest burden of hepatitis viremic infections, 5 countries are actually within the top 20 globally in terms of number of hepatitis C infections. Those countries, not surprisingly, are those with large populations in the region. So that's Nigeria, DRC Congo, Ethiopia, Angola, and Ghana. But when you go further down the list, there's other countries with relatively large burdens as well. Tanzania, Uganda, Cote d'Ivoire, Cameroon, and the list does go on even with high prevalence smaller countries in the sub-Saharan African region. So one of the themes of this talk that I hope you're able to take away is that hepatitis C is very unique in the sub-Saharan African region, particularly because of a high viral diversity of strains that are present in the region. So here in North Africa and Egypt specifically, we know that genotype 4 really predominates, but it's a very specific subtype of genotype 4. It's genotype 4A present here in Egypt, which is very different than the genotype 4 predominated infections in Central and East Africa, which tend to not be genotype 4A, but a long line of other subtypes that are very distinct from genotype 4A. If we look at the Southern African subregion, there's a smaller epidemic, but a very diverse epidemic, including genotype 5, which is very unique to the Southern African region. And then in West Africa, a large epidemic, very diverse in terms of genotypes, a large percentage of genotype 1, but again, infections that are not 1A or 1B, subtypes that were typically tested in North American and European settings, but rather genotype 1 infections that are not A or B, and we'll talk a little bit more about that later in the presentation. So just to speak very briefly about transmission, I think this was well covered in the abstract presentations that were given in the previous session, but we know that the data is quite limited. Anecdotally, we believe that a high burden of infections are from healthcare-associated infections, so due to unsafe injection practices, blood transfusions, surgical procedures, transmissions that we feel like are improving over time, which probably leads to a rather large birth cohort effect for hepatitis C in sub-Saharan Africa, being that individuals over the age of 40 or 45 at higher risk for being antibody positive. We also know that traditional practices, as mentioned in some of the abstracts, such as cutting, scarification, tattoos, that are specific to the region are risk factors for horizontal transmission. And the PWID populations in sub-Saharan Africa, although smaller in number than we think about in Eastern Europe or Central Asia, do have significantly high prevalence when tested and are still key demographics or hotspots for hepatitis C infection in the region. MSM has been notoriously difficult to quantify in the region, both earlier in the HIV epidemic as well as for hepatitis C currently. And then other modes of transmission, such as vertical transmission or heterosexual sex, we know are possibilities, but probably not driving the epidemic as they might be for other infections, such as hepatitis B or HIV. So I'm going to switch gears and talk a little bit more about clinical management, or the approach to the clinical management of hepatitis C in resource-constrained settings in sub-Saharan Africa. This is just a photo of one of our team members in Sierra Leone, in a very rural district in eastern Sierra Leone, where we've introduced viral hepatitis testing and care. This schematic here that's pasted, I know it's a little bit small to read, is a snapshot of the algorithm that was introduced in the WHO guidelines in 2018. The real take-home message from those guidelines is one of simplification, a public health approach, a simplified algorithm to hepatitis C testing, monitoring, and treatment. So in those guidelines, screening is still by serologic assay, either with a rapid diagnostic test or a lab-based algorithm, and then confirmed with a nucleic acid test by PCR. I think that's very clear and straightforward in hepatitis C management now. The guidelines did simplify monitoring quite a bit. So for patients without complications or co-infections, the guidelines are really recommending blood testing only at initiation and at endpoint, that being 12 or 24 weeks following the end of treatment. So recommending non-invasive fibrosis testing, a pre-Fib4, although we know that there's challenges and limitations to both of those. Testing for key comorbidities that might affect treatment course, such as HIV, Hep B, testing for renal and liver function. And then importantly, have phased out recommendations regarding routine genotyping at initiation of treatment. So again, that's testing at initiation. And then second test is at the point of SVR12 or SVR24 with a nucleic acid test as a test of cure, and then checking renal liver function at the end of treatment. A key concept in those guidelines is really the treat-all approach, so not waiting for patients to advance in fibrosis or progression of the disease, but rather to treat at the point of diagnosis. That's really supported by the fact that SVR reduces liver-related morbidity, mortality, hepatocellular carcinoma, and extrahepatic manifestations. That there's modest reductions in transmission as well from a treat-all approach. And it's really based on the fact that DAAs are now have such a high SVR rate and a great safety profile. Treat-all may also be easier to implement, and the long-term benefits economically may be substantial. There might be advantages in terms of decreasing price based on volume for key commodities like drugs and reagents. And then there's a real equity argument to treating all and providing the same treatment for all patients that come in the door. Treatment, just very briefly, was also simplified in the 2018 guidelines and going to pan-genotypic regimens only in the absence of genotypic testing routinely at initiation. So I think we're familiar with these guidelines, SOFDAC, SOFVEL, and GP being the three first-line treatments that are recommended both for patients without cirrhosis and with compensated cirrhosis. Some slight details there that we'll get to in just a moment in terms of special considerations. For patients with cirrhosis, I think this was well covered yesterday, that routine screening every 6 months for hepatocellular carcinoma in these patients is important, with ultrasound or with alpha-fetoprotein as available. And then in places where there's capacity for endoscopy, screening every 1 to 2 years for esophageal varices. In patients with decompensated cirrhosis, the guidelines recommend a referral to a specialist, and typically treatment with SOF and an NS5A inhibitor paired with ribavirin for 12 or 24 weeks, though those patients, as emphasized yesterday, require very close monitoring. And then patients, pregnant patients and children, data is rapidly emerging. More regimens are being tested and approved. We do know that for adolescents and children over 12, sofladiposphere, sofribavirin, and GP are all possibilities depending on genotype. And for children younger than 12, from 3 to 11, soft lidiposphere with some new approvals and other regimens quickly emerging as safe and effective in that vulnerable age group as well. In terms of key comorbidities, HIV, as we know, hastens the progression of liver disease for patients with hepatitis C and vice versa. And it's very important to note drug-drug interactions, even with the pangenotypic drugs, thinking about patients on ART, but patients particularly on NNRTIs such as nevirapine and efavirenz, in many of our contexts, still on those drugs, and I need to note those drug-drug interactions before beginning pangenotypic therapy. Endemic diseases such as hepatitis B and TB need to be screened before treatment of hepatitis C and treated before DAA therapy is initiated. And then conditions such as diabetes or depression, we know are extrahepatic manifestations of hepatitis C infection and may improve with achieving SVR12. So what are the outcomes to date in terms of real treatment experiences with DAAs here in sub-Saharan Africa? The data that's been published is quite limited. It's encouraging. It shows high SVR12 rates overall. But in speaking with many of you, I know that DAAs are starting to become more prevalent. We have cohorts emerging. And I really encourage sharing that data as much as possible so we can learn from your treatment experiences in your respective countries. Although that data has been encouraging for overall high SVR12 rates, I think the prospect of hepatitis C treatment failures in sub-Saharan Africa is one that we really need to consider very strongly. Dr. Berg spoke about this at length yesterday as one of the key concepts that we really need to look forward to in the coming years as pangenotypic DAA therapy is becoming more common and prevalent. I mentioned earlier that there's a high genotypic diversity of hepatitis C around the continent. This is a map that was recently published, shown yesterday briefly, that really highlights the genotypic and genotype subtype diversity of infections around sub-Saharan Africa, particularly rare genotype 1 subtypes, so ones that we consider that are not 1A or 1B. And rare genotype 4 subtypes that are not 4A or 4D. Now those are, the 1A, 1B, and 4A, 4D are the subtypes that were typically included in clinical trials that led to approvals of medications and indications for treatment. And these subtypes, as they're emerging and as knowledge about them is emerging, it's paramount that we actually understand where these subtypes are. Treatment failures have been noted in prospective cohorts here in sub-Saharan Africa, but also in databases of quite large databases from Europe retrospectively, showing that a disproportionate amount of treatment failures that occur in Europe and North America happen in immigrant populations with these rare subtypes. Those failures are largely driven by baseline NS5A mutations and are typically in patients that were treated with a previous generation of NS5A inhibitors, such as lidiposphere, declatosphere, umbidosphere. But those are medications that we typically consider first line in the context where we work in sub-Saharan Africa. So just as one example, this is from our work in Rwanda through the shared study. We treated 300 patients with soft lidiposphere for 12 weeks. And we found an overall high SVR12 rate for the cohort overall. But when we broke that down by these genotype subtypes, we noted a very limited response in particular subtypes that have a high baseline resistance. So all patients actually in that cohort had NS5A resistance mutations at baseline. And of those that failed, they typically had 2 to 3 resistance mutations, leading to reduced susceptibility to a drug like lidiposphere. So where does that lead us? I think many of us are still struggling to get first-line therapy out there, but I think we should do that with the knowledge that there could be a higher rate of failure for regimens that are based on lidiposphere and declatosphere. And there have been some approved drugs for second-line therapy. Sofpelvox is one of them, GP is another in limited genotypes. But there's no experience for those drugs in rare genotype 1 and genotype 4s. It's on a case report basis. We've seen very small numbers of patients treated with those drugs. And more importantly, those drugs are not available here in our context. So what we find is a very non-standardized way of treating patients with NS5A treatment failures. I've been speaking with many of you and what your clinical practice is, and finding that primarily it's retreating, again with an NS5A based regimen, often for 24 weeks, often by adding ribavirin. But we don't know how we're performing with those second-line regimens. And I think it's very important that that data comes out, that we understand how effective those types of regimens are. So I think key take-homes about this real prospect of treatment resistance in sub-Saharan Africa is that SVR12, the test of cure, a nucleic acid test 12 or 24 weeks after therapy, is absolutely essential. We have to make sure that patients come back for that test of cure, that we need more subtype diversity data from each and every country in the region. We want to know what the treatment outcomes are in these rare genotypes, both for treatment naive and treatment experienced patients. And to really be thinking ahead and how do we gain access to drugs both as first-line and as second-line therapies that are proven in these subtypes, in these genotypes that are very much prevalent in the countries where we work and that were not represented in initial clinical trials. So just my last few slides, I want to describe what we've seen in the HCV response so far in sub-Saharan Africa. This is a hospital where we work in a southern, very rural county of Liberia called Maryland County, where we've introduced integrated viral hepatitis screening, testing, and treatment. Yesterday, Dr. Ward showed this slide as well, really just to highlight that the Afro region does lag behind others in terms of testing coverage and treatment, treating less than 3% of estimated infections in sub-Saharan Africa. And Dr. Leshy showed the Hepatitis Dashboard, which is really monitoring, developing a first monitoring framework for really assessing country progress towards key elements in the national frameworks for viral hepatitis. However, we still know that only two-thirds of countries have a viral hepatitis focal point within their central government. Only about a third of countries have a technical working group for viral hepatitis. Only half of the countries in the sub-Saharan African region have national plans developed, and only half of those have been costed or published. And only about 15% of countries have targets associated with their plans. The challenges, I think, have been well highlighted. We know them, right? Awareness, both in the public, by providers, by policymakers, needs to increase. We need to have better data on epidemiology. Who are the key populations that we need to be testing? What is the genotype mix and potential resistance to first-line therapies? Testing coverage and integration. How do we really make sure that testing is available within our primary care systems? The registration, access, and financing of key commodities, reagents, and drugs. And then what we'll be talking more about this afternoon, I think, is how do we develop the champions and political will, as has been happening in Egypt, in countries around sub-Saharan Africa. Is there some space for optimism? I think there have been some key improvements over the past few years. Blood supply screening we know is improving, safe injection practices, training and supplies for that, the simplification of the guidelines, as I was mentioning before. The cost of key reagents and drugs has been declining rapidly, though still very much out of reach for many national country budgets and patients. And then improving governance and awareness, although still far from where we want to be. What's the future for viral hepatitis? I know many of the countries where you're working or struggling just to have drugs, just to have laboratory testing, how do you make that financial argument, that return on investment case study for treating viral hepatitis in your countries? And I think some of that work has been done for us. In thinking about UHC, which is universal health care, universal health coverage, is a political commitment by many governments now to provide a broad package of services to their populations at a low cost or at an affordable rate. And the study that I'm highlighting here showed that for 1.5% additional investment, note that viral hepatitis was not included in the original UHC package, can result in 5% decreased morbidity, 5% decreased mortality and 10% decreased morbidity. If we just remember that, 1.5% additional investment can lead to 10% decreased morbidity, 5% decreased mortality. I think that's a powerful argument to use when speaking with policymakers. And several countries have taken that farther to make investment cases within their own countries. I'm not going to go into detail here, but South Africa, Nigeria, Ethiopia have all costed hepatitis C care in their countries and have found that to be cost-saving or cost-effective. Just a final example from Rwanda. Dr. Makuza did a great job describing the amazing accomplishments that have happened in Rwanda. I hope he has a chance to describe that in the roundtable session more this afternoon. But in Rwanda, they found if they could target screening for 4 million people over the next 5 years and treat approximately 100,000 patients, they believe they can achieve elimination targets within 5 years. They've already treated 15,000. And they've costed the entire 5-year package to be less than half the annual budget for HIV, which gives us optimism that this is not only possible, but that by integrating within HIV funding streams as well as platforms of care, that could be potentially achievable. So thank you very much. Thanks to the COLDA organizers. I think this is a wonderful opportunity for us to share information and collaborations moving forward. Please email me if there's any potential there. So thank you very much.